My dear students, in this video, I am going to discuss some of the salient points regarding the use of steroids or corticosteroids in community-acquired pneumonia. We often face the ambiguity in which patients to use steroids and which patients not to use them when both are actually having community-acquired pneumonia. Now, whatever evidences exists and whatever guidelines say on the basis of distinct observations in the clinical trials, I have tried to just collate them together and present so that it is easy to remember. Let us start with a case. A 45-year-old male, diabetic and hypertensive, presents with 3 days history of fever, productive cough, dyspnea, along with altered sensorium since morning. On arrival, he is having a respiratory rate of 36, saturation of 84% on room air, a blood pressure of 88 by 54 mmHg, heart rate of 118 per minute, and temperature of 39.2 degrees centigrade. The chest X-ray shows bilateral multilobar infiltrates. The ABG on non-rebreathing mask shows a PF ratio around 160. The labs reveal a WBC count of 19,000, CRP of 220 milligrams per liter, procalcitonin is elevated, the lactate is 3.8 millimoles per liter. So the patient is diagnosed as having severe community-acquired pneumonia. In the initial phase on the ICU, the patient is administered broad-spectrum antibiotics within 1 hour and resuscitated with fluids at 30 ml per kg of crystalloids. Noradrenaline is started to maintain the desired MAP of 65 mmHg. The non-invasive ventilation was attempted, but that led to worsening hypoxemia, and therefore the patient was intubated and mechanically ventilated. Now the diagnosis is severe CAP with septic shock. Now the question which needs to be answered here is that should corticosteroids be started in this patient? Now, in the first place, why were corticosteroids or steroids considered in patients with community-acquired pneumonia? This is because community-acquired pneumonia is not a manifestation of infection alone. It is a consequence of both infection plus dysregulated host inflammation. And in severe community-acquired pneumonia, the inflammatory response can drive to produce ARDS, to produce septic shock, and to produce refractory hypoxemia. Now, corticosteroids blunt this excessive inflammatory cascade, and thereby they reduce the cytokines, reduce the capillary leak, and reduce the alveolar damage. If you look into this slide, it will be clear to you that the immunosuppressive effects are not confined to preliminary things. They are confined. They are causing inhibition of expression of the inflammatory cytokines like interleukin, chemokines, and TNF alpha. They are also involved in the suppression of synthesis of prostaglandins by blocking the enzyme COX-2 and the production of leukotrienes. They cause suppression of the tumoricidal and microbicidal activities of the activated macrophages and neutrophils. The immunosuppressive effects on dendritic cells maturation and function, inhibition of the T cell activation of the maturation of the double positive T lymphocytes, and therefore they produce a gamut of immunosuppressive effects by which they hinder or blunt this excessive inflammatory cascade. And that is their importance or reasons for consideration in severe CAP. Alongside, they also cause some problems, and these problems may manifest in the form of acute kidney injury, hyperglycemia, or gastrointestinal bleeding, although they may not be serious in most of the times, but there are also biological explanation to some of these effects. Now, when we talk about community-acquired pneumonia and severe community-acquired pneumonia, we mean certain specific benefits that we expect from the use of steroids. And this benefits is in the lungs. They produce a reduction in the alveolar capillary leak. They reduce protein-rich edema. They reduce the neutrophil-driven alveolar damage. And they reduce the hyaline membrane formation. Now, all of this translates into specific bedside effects, which are advantageous or benefits like improved PF ratio, reduced FiO2 requirement, less progression to ARDS, and easier liberation from ventilation. Consequently, other than the lungs, there is also, because of septic shock, in severe CAP, there are hemodynamic effects, and these hemodynamic effects lead to or is to restore the vascular adrenergic sensitivity, suppress the nitric oxide synthesis, replace the relative cortisol deficiency. Now, all these are effects of steroids on the hemodynamics, and as a result, there are benefits which are accrued in the form of reduction in the vasopressor dose, faster shock reversal, and less catecholamine toxicity. Now, this is because of such the beneficial effects on the hemodynamics that surviving sepsis campaign supports hydrocortisone in refractory shock. Now, these benefits are also manifested in patients on community-acquired pneumonia who are with septic shock. Now, let us look into some of the major pertinent randomized control trials which assess the corticosteroid treatment in patients with severe community-acquired pneumonia. In 2023, it was DeQueen. In Meduri 2022, 31 centers in France, 42 centers in US. The Hemming then there was the Approaches RCT, the Torres, which was a very famous study, which was done in 3 centers in Spain, the Sabri, the Confalonary in 2005, one of the early trials, and the earliest was by Madik et al. At one center in 1993. And in majority of the trials, there was reduction in the 28-day mortality, reduction in 90-day mortality, or reduction in treatment failure rate. In some studies, there was improvement in the PF ratio and the SOFA score by day 8. And in some studies, there was also improvement in PF ratio and mortality. Only 2 studies produced no reduction in mortality or no effect on the serum TN alpha levels, which shows that majority of the studies had some benefits, either in the form of mortality or in reducing treatment failure or in the PF ratio and SOFA score by day 8. If we look into the adverse effects that they have studied, the corticosteroids in the acute use of this, in the treatment of severe community-acquired pneumonia, the analyzed trials and meta-analysis suggested that they are not associated with a higher incidence of adverse effects such as hospital-acquired infections, GI bleeding, and AKI. And some studies, though, said that they probably increase the risk of hyperglycemia, but close monitoring of glucose levels and appropriate management strategies should help mitigate this risk. Therefore, it is not very difficult to control these side effects or take appropriate measures so that their effect can be minimized. If we look into the landmark trials and just take a brief uh, review of those trials, the ones that strikes the most importantly is the Cape Cod trial, which was published in NEJM in 2023, where early IV hydrocortisone in severe CAP was found to reduce 28-day mortality and also reduce the need for intubation and vasopressors. Now, this is one of the trials which strongly purported the incorporation of corticosteroids in the guidelines, in the major guidelines for use in severe CAP. The Torres study, which I had shown in the table in the 2 slides back, also was one of the large studies which showed benefit, but this benefit was confined to patients who had a high CRP that was more than 150 mg per liter. And if you look into the meta-analysis, which included the studies that were published between 2019 to 2024, there was consistent mortality reduction only in severe CAP. And that is why we have also seen in the trial list that the benefits were accrued in severe CAP in some form or the other. So what does evidence says? Evidence says that if it is severe CAP, the benefit exists when the steroids are used early. They should be used early in severe CAP, and the key outcomes improved are reduction in mortality, reduced need for mechanical ventilation, reduced progression to ARDS, and reduced time to clinical stability. But if it is non-severe community-acquired pneumonia, there is no routine role of steroids because there is no consistent mortality benefit and there are risks, the risks of hyperglycemia and secondary infections, and they may outweigh the more modest gains and slightly faster symptom resolution. But because of these risks, they should not be used as a routine. The strongest signal for their use in ICU patients with septic shock, with high inflammatory markers like CRP and IL-6, and severe hypoxemia or refractory hypoxemia. So what do guidelines say? The ITSA ATS 2090 guidelines is against routine steroids in CAP, and they say that we use only if it is refractory septic shock. ASICM 2023-24 expert updates support early use low dose steroids in severe CAP, especially in ICU patients. Now, this may apparently seem a bit contradictory. Why ITSA or ATS is against routine steroids and why did not mention about severe CAP? Now, this is the time in 2019 where the ITSA guidelines were based upon, and they were based upon trials which were heterogeneous. Mortality benefit was inconsistent, and there were concerns about hyperglycemia, secondary infections, and influenza associated harm. So the important nuance which were missed include that these guidelines predate the landmark Cape Cod trial of 2023, and they were written when the CRP guided therapy was new and ICU specific trials were underpowered. And that is why the ITSA ATS 2019 recommendations did not mention strongly the use of steroids in severe CAP. So what should we do in ICU? The practical approach that we should, that who should get the steroids? If it is severe CAP requiring ICU, if the patient is on septic shock, especially vasopressor dependent, if the PF ratio is less than 200, high inflammatory response with a CRP of more than 150 milligrams per liter, and CAP which is progressing towards ARDS. Who should not get steroids? If there is a strong suspicion of influenza, community-acquired pneumonia, unless the patient has gone into ARDS or septic shock, if the patient has uncontrolled diabetes, if the patient has active GI bleed, or if the patient is either suspected or confirmed in having untreated fungal or TB infection. So why is this benefit only confined to severe CAP? Because in mild CAP, the host response is proportionate, inflammation is protective, and steroids blunt bacterial clearance. Whereas in severe CAP, the inflammation is maladaptive, the tissue damage is more than the pathogen damage, and the steroids prevent host-mediated injury. And this is the reason why mortality benefit appears only in ICU populations and also in CRP-guided strategies. They seem to work. So what should be the dose, drug, and duration? The preferred regime according to the best evidence available is hydrocortisone 200 mg per day IV. They can be administered either as continuous infusion or 50 mg IV 6 hourly. Should be started within 24 hours of ICU admission. The duration should be 5 to 7 days, and usually tapering is not required. Alternatives are there, but less robust data is available for them. These are methylprednisolone 0.5 milligrams per kg per day and dexamethasone 6 to 10 milligrams per day. But whenever we use, we need to watch for the adverse effects, which are hyperglycemia, which is very common, but which can be controlled by insulin infusion and titration to that effect. Secondary infections, they are usually late. ICU acquired weakness can occur after prolonged use, which is not advocated, and occasionally there can be delirium. So my final take-home message would be steroids are not for all patients with community-acquired pneumonia. They do save lives in severe community-acquired pneumonia, especially in ICU patients. And when severe community-acquired pneumonia, if a patient is there in ICU, we need to start them early, use low-dose hydrocortisone, and also keep the course short. Thank you.